Okay, hello and welcome to this presentation. My name is Leo. I'm a physical therapist, and this is going to be all about inline dynamometry, which is a really cool strength testing technology. We initially did this in person, but there were enough people that couldn't attend that we thought it'd be worth just doing a recording and then sending it out to whoever was interested. So, a bit about me before we get going. Academically, I did my undergrad in biopsych at University of Victoria, and I went over to Toronto and did my master's in physio at U of T and stuck around there for a few years before moving home just 4 or 5 months ago. Athletically, I played soccer a lot as a kid. That was my sport. Recently, I've gotten a lot into Muay Thai and kickboxing, which has been a lot of fun. I do a lot of things at a mediocre level. I'm an inflexible yogi, a slow runner, and a relatively weak weightlifter. But I try. Clinically, I have a special interest in combat sport athletes. I just find them really fun to work with, whether it's jiu-jitsu, wrestling, Muay Thai, which is what I have been practicing recently. Obviously, I understand the demands of soccer very well, so I enjoy that population, treat a lot of runners, and then I also treat a lot of older adults with osteoarthritis and osteoporosis. So, outline for today, we're going to chat about inline dynamometry through the lens first of an ACL case study, which is going to be on me. We're going to talk about isolated versus integrated testing methods for strength. We're going to define functional. We're going to chat dynamic systems theory along the way. And we won't do a practical demo because obviously we're not in person, but I'll show you guys some pictures just to get a sense of what a setup could look like. So first off, what is inline dynamometry? It's basically just an objective way to assess force where a load sensor is being pulled from a fixed surface and it transduces tension into measurable electrical output. So practically speaking, in the clinic, I can look at a certain muscle group, get somebody to pull against a fixed surface, and we can measure how much force they're putting out, which is really, really useful. This is the Tyndek Progressor, which is the specific Bluetooth-enabled app and dynamometer that I use in the clinic. It's been really fantastic, but you can also purchase just a slightly less expensive crane scale, which will read out the force measurement right on the device itself, but obviously doesn't save people's scores and doesn't have an app which with all sorts of bells and whistles. The Tyndek's nice because it's enabled for peak force, rate of force development, and endurance. Let's get right into it, though. Without any further ado, let's make it practical. Case study. So case study is me. That is me before I had a beard. I was like 15 there, and I tore my ACL and my PCL playing soccer. It was managed non-operatively, and I returned to sports in 5 months. What my rehab looked like from that injury was a lot of functional exercises, a lot of balance work, a lot of slide board work. I remember using that machine a lot, ton of glute work, a lot of ultrasound and stuff like that, to be honest, as well. And a lot of movement retraining to avoid valgus. So step downs and like keep your knees straight type of thing. Now it all seemed good and fine at the time. I went back to soccer and, how did it go in the aftermath? I didn't re-tear my ACL, but on my left side, the affected side, I had a fibular fracture, shin splints, 3 adductor strains, 2 hip flexor strains, conservatively 1 million ankle sprains. I also had a osteitis pubis, which now I kind of conceptualize as a pelvic bone stress injury. I also sprained my meniscus on that left side just recently, actually. And then on my right side, 1 adductor strain. So basically, a ton of stuff went wrong on my left side over the years. And I think it's an interesting example of where I might have benefited from being assessed using an inline dynamometer. So 10 years later, I finally assessed my quad strength using an inline dynamometer, which I had just picked up. This was, I guess, back in 2022. So just a couple of years ago, right? My right side, unaffected, was 181.3 pounds. My left side was 74.3. So as you can see, I'm pulling against that fixed surface. You can't fully see it, but the Tyndek is set up to kind of attached to my shin there. And as we can see here, that is a 41% limb symmetry index, which is no bueno. We want 90 plus to have a really good outcome after an ACL injury. So that was kind of a shocking revelation. The question is, what was my rehab missing? And I think I have a good idea what it was missing, which is isolated capacity restoration. I did a lot of glute work. I did a lot of slide board work, but I didn't really restore my quads. And we know that when it comes to ACL, it's cut and dry. If you have a quad index greater than 90% and you're more than 8 months post-surgery, you have an 84% increased risk from, on a relative standpoint, of a re-tear relative to somebody who has a greater than 90% limb symmetry index and who's more than 8 months post-surgery. So that data comes from a cohort study, which shows the absolute numbers of 38% sustaining a tear if they had, less than a 90% limb symmetry index, so more than 10% of a deficit side to side, and also if they were less than 8 months post. So I never retore my ACL, but I had a ton of issues that happened on my left side. I'd be really curious to see, a cohort study where they looked at asymmetric, just long-term injury rates. It's a study that could never be done, but I'd be really curious. Now, I didn't get a quad index done back in the day because the clinic I was at didn't have a dynamometer, or they didn't, care about that. Just it wasn't part of their thought process. Why is that important? The quad index, which you can measure using the Tyndec, answers a simple capacity to do work question. Before capacity can transfer to a task, it has to, exist. And that's from Eric Mera, whose awesome hip and knee course was very influential for me. I think he offers it online, so highly recommend that to anybody. Sometimes a coordination problem is a coordination problem, but sometimes a coordination problem is a capacity problem, meaning sometimes the movement doesn't look the way you want it to look, not because the person doesn't know how to move in a certain way. It's because they don't have the one component, like the piece of the puzzle, the building block needed to produce that movement solution. And how do we know which is the case, whether it's a coordination problem or a capacity problem? We have to assess capacity. Here's my quads update from this is from a few weeks ago when I did this presentation, but it was like a lot better. So 173 on my left, like up 100 pounds. How did I do that? Did a ton of isolated work, ton of leg extensions, ton of hack squats, ton of machines, which was something that I wasn't doing a lot of prior. I was just doing barbell work, and I guess I was able to hide my quad, right, by probably shifting one side or using a hip strategy, whatever it was. So let's chat about when isolated capacity testing matters. I would say it matters when we have high level task demands. So if somebody's going back to sport, it's really important because they're going to be taken close to their ceiling of what they can do. And they don't want to be, you don't want to go back to a deceleration sport without a quad. Let's put it that way. Post-op scenarios are the clearest example because we have research to show that capacity deficits lead to re-tear, increased injury risk. Kind of return to play after post-op, right? These are the scenarios where they really matter. When does it not matter? Probably less in chronic pain scenarios. We know strengthening can help people in pain. We know resistance exercises can help people in pain, but we don't know whether strength is what mediates that recovery. So there's tons of ways exercise can help with pain, increase self-efficacy, top-down neurophysiological effects, exercise-induced analgesia. There's all this sort of desensitization researched. So exercise is great, loading is great, but it's tough to say for somebody that has chronic widespread pain that, your widespread back pain got better because your lumbar paraspinals got stronger. Like, no, there's a lot more to it. So I just wanted to point that out. This is a great paper that's worth a read if you're curious to explore that perspective more. Let's pivot to a practical kind of clinical example. What could cause this movement strategy? So this is what we would call valgus, right? We see knee abduction, the shank abducting relative to the femur. And a lot of people would have a lot of different answers to this. It could be a bunch of things, right? It could be a habit. It could just be the way they learn to move. It could be their Q angle. It could be, those hips the pelvis being wider. And that's just kind of the way your body is structured, your shape. Traditional explanation would be weak glutes. We'll go back to this. Oh, your hip abductors are weak, so your knee is caving in. That would be the 2008 explanation. There's been some very smart people. Eric Mera is one of them, who has provided the hypothesis that it could actually be the opposite. It could actually be that your hip abductors, your glutes are in a more leveraged position from a more hip adducted position. So from a length tension standpoint, that hip adduction compensation that creates valgus might actually be because they don't have quads and because they're using their hip. If you could just bend your knee forward, you wouldn't need to go into this crazy adduction moment. Now, obviously, bottom line is we don't know, right? Unless we assess, which is the whole point of this, that we need to assess capacity. This is like a conceptual way of understanding how people will interact with their environment and the task to produce a movement solution. So the organism interacts with the task and the environment to produce coordination and control. We self-organize around the constraints of the environment and the task in order to move a certain way. And people will take the path of least resistance. They will do whatever they're going to do with the tools they have at their disposal and the environment that they find themselves in. So for me, it's almost more important to just make sure that the constraints and, from a biological perspective, the organismic constraints, the constraints of their tissues are such that they can use them, right? Rather than just trying to contrive a certain movement pattern through movement retraining. Now, let's go back to the ACL example. What do we know happens after ACL injuries? People use their hips and they don't use their knees. So this study looked at a forward lunge and just showed what we all know in clinic. You see increased hip extensor contribution and less knee extensor contribution. And how that would look is a little bit like this. We see on the left is somebody using their knee, on the right is somebody using their hip. Now we can kind of express this from a physics standpoint using a moment arm diagram, right? So if on the right, the forces going into the ground is represented by that blue arrow, right? That's the direction of their momentum. That's the force vector. We know one of Newton's laws, right? Force goes in an equal and opposite direction, up, back through the floor. So ground reaction force is that big red arrow. Now, the moment arm is the distance between the ground reaction force and the axis of rotation, which is the knee. It's tiny on the right. So we're not using our knee extensors. We're using our hip extensors. On the left, we're staying much more vertical with our trunk. And you can see that makes the ground reaction force a lot more horizontal, which places a much higher moment arm on the knee extensors. So that's a very quad dominant stance, which is, when you break it down that way, it makes a lot of sense. But if you saw that in clinic, it's a little bit subtle. If you weren't sure what you were seeing, you might have to go in and actually look at the component parts, right? This is just an Eric Mayer quote. There are no right or wrong movements. There's only physics. I'm not saying the right side is dangerous. The left side is dangerous. It's just putting stress on certain tissues. And it's a worthwhile application of biomechanics. Like, people give biomechanics a hard time, honestly, sometimes. But the question of just how to allocate stress to a certain tissue, you need to know your biomechanics in order to do that. The reason, though, that the hip strategy might not be optimal is because the ACL injury mechanism actually happens in what looks more like the hip strategy than the knee strategy. So we know from research, it was Koga 2010, here's the paper, I'll flip back to that in a sec, that ACL injuries happen invariably at about 20 to 30 degrees of knee flexion. This is the same angle we do a Lockman's test, right? For a reason, because it tensions the ACL maximally. And it typically happens with a rapid change of direction to initiate a pivot. We see a lateral trunk lean over that ipsilateral side. And what would allow us to prevent that? Just being able to decelerate using knee flexion. So if we have a good knee extensor mechanism that's strong and can decelerate forces, we might not find ourselves in that funky position. Now, obviously, things can be inevitable, but that could be one of the reasons that quad strength is so protective against future ACL tears. This just shows they looked at 10 injuries from handball and basketball. They were ACL injuries, and invariably the knee flexion angle was less than 30 degrees. So valgus isn't dangerous. Valgus on a straight knee is dangerous. It's a little point to remember. And then this just, on the right, we're in less flexion, right? Just to drive that point home. Couple takeaways. All roads lead to Rome from a movement strategy standpoint. I'm a movement optimist. I think people can move in a lot of different ways, but it's better to have a hip and a knee than just a hip. And movements with high degrees of freedom, where people can solve a problem in multiple ways, do not reveal specific impulse generation deficits. Back in 2022, when I assessed my quads and found out how weak they were, I was front squatting like 1.5 times body weight. And obviously I was, using a hip strategy and probably shifting my weight to my unaffected side and whatever else. But it wasn't clear just from doing compound movements that I had a really weak quad. So big picture, what is my role? Changing movement patterns or restoring general physical capacities? I lean more towards the latter. However, they're not mutually exclusive. You can do both. and the latter affects the former. If we restore general physical capacities, whether it's quad muscle, hamstring, whatever kind of injury we're talking about, that's going to change somebody's movement patterns, right? And it might go the other way as well. To be honest, if we actually can cause some movement retraining, then that could be a way to isolate certain tissues and exercises. But long story short, we don't need to be on one side of this argument. It's just important that we don't miss the basics. Enter inline dynamometry, right? So this is how we assess isolated capacity. And obviously, historically, the gold standard for this is the Biodex isokinetic dynamometer. The pros are, you can use constant speed, super detailed analysis. The cons are that it's like $1 gazillion. So if you have one of those, you can just tune out of this talk right now, because there's no need for you to be here. Commonly used alternative, apart from the inline dyno, is the handheld dyno. So these are great for small muscles like external rotation. If I'm just testing somebody like this, I can break their force. However, not great for something like quads, because I can't push down 200 pounds against somebody's strong quads, right? This is it was where inline dynamometry comes in, relatively cheap, $200 to $300, rated up to 300 kilos. So unless you're treating like an elite power lifter who's doing a mid-thigh pull of 700 pounds, then you're good. You're not going to have anybody break the machine. It has been validated against isokinetic dynamometry, which is really important to note. Just a quick digression on resisted isometric muscle testing and manual muscle testing. They're valid against gravity, basically up to the point of can you lift against gravity. Beyond that, they're more of a subjective symptom tolerance test, right? So does it hurt to exert some force with your quads? Cool. The one on the right can measure that, but it's not really objectively measuring strength, right? Because it's just oh, how strong am I? How strong are you? Are you a 3+? Are you a 4? Are you a 5? I don't know, right? Same with the left, the lateral step down. It's assessing whether you can do a lateral step down. It's a kinematic evaluation. It's not a truly objective. Yeah, so it's you could be objective with respect to the angles, but it's not objective with respect to you have strong quads. That can only be assessed through isolating the tissue. So before we get to just chatting about how to do this practically, a common issue that people get hung up on is, are isolated tests and are isolated exercises even functional? Is it even functional, bro? You know what I mean? Now, this is a huge debate in the industry. The term functional is very nebulous and annoying. But, a lot of people on one side of the argument would say that to be functional, actually, I had this slide here. A lot of people would say that, functional exercises need to be standing. They need to have lots of degrees of freedom. They need to have, they need to be complex. They need to involve multiple joints, and they need to mimic the task, right? So the more it looks like somebody's goal task, the more functional an exercise is. I think I have this summarized here. So yeah, multiplanar, multi-joint, simulates the goal task, closed chain. Those are the hallmarks of functional exercise. The ultimate functional exercise is the sport itself. It's just having the person do the task they're trying to get back to, we don't need, so early on, right? If you're trying to have a tennis player do all their rehab with a tennis racket in their hand, it's just silly, right? I would sometimes make the weight room and the rehab process just a watered down version of their sport. And I don't think that was very smart. Now, sometimes I ask myself instead, what do they need that they're not getting from their sport that I can give them in the clinic or the weight room, right? Functional to me is so here's my annoyingly broad definition. Functional exercise is anything which moves a person closer to their goals. It can be elaborate, it can be simple, it can be multi-joint, it can be single joint. Context is king, but anything can be functional, right? It doesn't have to look like their desired goal task. It doesn't have to be standing on one leg while they're, juggling a tennis ball and, reciting the alphabet. We can make a simple exercise very functional. And, if having a quads index of greater than 90% reduces your re-tear risks significantly, absolutely leg extensions are functional. It'd be hard to argue otherwise, I would say, if we're, connecting the point that leg extensions are a good way to increase quad strength, which they are. Now, if somebody doesn't have a quad and you can't control knee flexion during a deceleration task, I could argue that closed chain work, like a squat, is less functional than knee extension because it allows for compensations that the person might habitually learn and then struggle to to change over time, right? So my job is to put people in a position to succeed without thinking too hard. This is Russell Westbrook briefly forgets how to dribble after thinking about it too hard. This is a picture from the Eric Mara course that I took as well. Another quote here: task-driven movement cannot be thoughtful and intentionally organized. The goal should be fearless, thoughtless movement, right? That was Louis Gifford's phrase. Humans are very task-oriented. They're going to solve the problem however they can. It's all about giving them the tools with which to do so. This is circling back a little bit to these circles. Task, organism, environment. What can I change? Sometimes a way that I conceptually approach somebody's rehab is like, which biomotor abilities, organismic constraints can I affect, right? Strength, range of motion, endurance, movement variability, self-efficacy, confidence. There are certain things we can change or certain things we can't. I like to place my bets more on things that I know I can affect. Task constraints, example of something I can affect, right? Similar to putting somebody in leg extension to get more quads. If I was going to do a squat, I could load them anteriorly. I could elevate their heels. That's going to allow them to keep their center of mass back in space, increase the moment arm on the knee. That's going to be way more beneficial if I want quads than just a word salad of verbal cues about staying vertical. This is a great little post from Alec Blennis. Trainers will actually say things like master free weights before machines and then use every constraint imaginable to improve stability to get a beginner to actually do a free weight exercise properly. So often, people demonize machines because they're seen as like simple and they're not complex, but they're designed in a way to isolate stress allocation to a certain tissue. And we should make use of that in training and in rehab and see that as a tool. There's a time and a place for a lot of different things. It just depends what the goal is. And we have to reverse engineer what are we trying to get out of an exercise. And sometimes a leg extension is going to be the best way to get quad strength out of an exercise, but there's a time and place for a back squat and there's a time and a place for balance work. And these things aren't mutually exclusive. It's just useful to make sure we're not demonizing altogether a certain class of activity. So let's chat a little bit about practical application. When it comes to testing, we want to test typically at mid-range because that's where the quads have most cross-sectional area. Not the quads. I'm obsessed with quads, as you can tell. For the quads, though, that's 60 degrees. For the hamstrings, it's 90. It differs muscle to muscle, but typically, you want them in a neutral position because that's where they can produce the most force. Sometimes you might want to test at end range, though, right? You might want to do like a shoulder external rotation test up at 90 in like a max kind of concentric orientation of the muscle. Consistency of the angle is key. So I will often use a goniometer to measure where I'm at so that I know I'm consistent. Do 3 tests, take an average, ideally perform after a warm-up so that they're not just doing it cold. And also another key, if we remember our definition of torque, which is force times perpendicular distance of the force to the axis of rotation, we need a perpendicular line of pull, right? Otherwise, we can't really measure torque accurately. We have to, include like sine and cos and whatever physics will give you PTSD back to biomechanics class. Okay. So here are a couple of examples, right, of me setting up dynamometry testing. So this is me, my old clinic. On the right, I'm doing hip abduction. As you can see, I've got the hip in a relatively neutral range. I've got a chain attached to the table, which is attached to the tin deck by a carabiner. Carabiner is then attached on the other end to a strap, which is fixed at my ankle. And I'm just pulling isometrically. On the left side, I'm doing shoulder external rotation up at 90 degrees and same setup, right? All you need is a chain, a couple carabiners, and I'm just holding a strap or holding a handle in that situation. You can be super creative. You can test quads, you can test hamstrings, you can test glutes, you can test shoulders, internal rotation, external rotation, lots of applications. Those are the most common ones that I find myself doing. And if you want, specific details, I'll have my email at the end of this. If you want to chat about, practical application in excruciating detail, feel free to get in touch. This is just lastly a really good app from a brilliant physio down in Portland, Scott Morrison. I think he's in Portland. Physiopraxis, I think is his handle on Instagram. And he developed this really neat app which allows you to normalize like your raw force score, because the app will give you just kilograms or pounds. And if you measure the distance between the where this like the distal limb is and the axis of rotation, and then you input the patient's weight, you can get a Newton meter per kilogram value, which we have some research to show some norms, right? So for quads, 3 Newton meters per kilogram shows really good patient outcomes. So that can give you some good targets to work towards. I'm going to skip through these. So yeah, if you have any questions, feel free to reach out. You can email me at the address listed there, or you can shoot me a DM on Instagram at leo.physio. If you or any of your athletes that you work with, if you're a coach or your trainer, feel like that you or they could benefit from an assessment, feel free to reach out. Just Google my name and there should be links there to book a consult. And yeah, hope you got something from this.